Hello and welcome. I'm Jeunesse Castonguay, VP at Clarius. We're so pleased you could join us for today's live webinar on emergency POCUS, techniques to differentiate causes of dyspnea. Emergency physician Dr. Frenkel will join us in a moment to teach point-of-care ultrasound essentials for assessing patients presenting with acute dyspnea in what promises to be a highly dynamic and educational session. You're among 1,000 acute care and outpatient clinicians who registered for today's popular session. And today we'll be showcasing the FDA-cleared Clarius PAL HD3, our new wireless high-definition scanner that fuses a phased plus linear array on a single head. Now, no matter which point-of-care device you have in hand, today Dr. Frenkel will demonstrate a step-by-step approach you can use for performing a focused set of cardiac and lung ultrasounds to better assess your dyspneic patients at the bedside. Is your patient suffering from congestive heart failure, COPD, maybe a submassive pulmonary embolus? Dr. Frenkel will demonstrate how POCUS is the fastest, cheapest, non-ionizing way to get rapid answers when seconds count. Following the main presentation, Clarius Clinical Manager Shelley Gunther will be performing live POCUS scanning. This 5-minute demonstration is a chance to see the new Clarius PAL in action. Available now in the USA, this new dual-phased plus linear array scanner offers the broadest frequency range and greatest image depth of any handheld. We'll see how it can deliver unsurpassed versatility, superior image quality, and streamlined workflows in any clinical setting. At any time during today's webinar, please use the Q&A box to ask your questions. Dr. Frenkel will address questions in the live Q&A following the presentation. Let me now introduce you to Shelley, your host for today's event. Shelley is an experienced sonographer with over 25 years of experience as a clinical ultrasound expert. As clinical manager at Clarius, Shelley is dedicated to providing the highest quality educational content for clinicians looking to add wireless ultrasound to their practice. She helps us deliver practical webinars like today's event and video tutorials for our Clarius Classroom, which now features over 450 on-demand video tutorials. Hi, Shelley, and over to you.
Hi, Jeunesse, and welcome everyone to this fantastic webinar. I've been looking forward to this webinar for a couple of reasons. The first, it's a great topic. The second is I get to show off our new PAL scanner. And the third is that I get to host my colleague and friend, Dr. Frenkel. Now, before we get started, POCUS has come a long way in recent years, and particularly when it comes to scanning the lungs and evaluating lungs in different ways. And there's been a lot of literature on this subject. And this first paper that I'd like to share with you is an abstract that discusses the value of ultrasound in patients with dyspnea. Now, historically, ultrasound was considered inadequate for assessing the lungs because of the artifacts generated by air in the lungs. But in recent years, we've really learned how to interpret these artifacts and use them to our advantage, as you're going to see shortly. And next paper is a recent clinical review, and it focuses on the pathophysiology of acute dyspnea and includes, to a large extent, point-of-care ultrasound use in the diagnostic workup that can differentiate different causes of dyspnea. So, like I mentioned, when I first started doing ultrasound, there's no way lungs were kind of no man's land. So it's really been exciting to see the developments over the last several years. Now, just before I introduce our guest today, I'd like to know a little bit more about all of you watching today. So please take a moment to respond to this poll. Now, how frequently is it that you use ultrasound when examining patients with dyspnea? Are you using it daily, just once in a while, or are you even just learning today? So let's just give a couple of more seconds to close out the poll. 3, 2, 1. Great, so a lot of you are just learning today. So we've got some weekly and daily users as well. So kind of across the board, but yeah, if you're just learning today, you're gonna get some great information from Dr. Frenkel. So now I'd like to introduce our speaker. Dr. Frenkel completed his MS and MD simultaneously at the University of California Joint Medical Program in Berkeley and San Francisco, completing his residency in emergency medicine, followed by fellowship in point-of-care ultrasound at Alameda County Medical Center in Oakland, California. Dr. Frenkel now works as an emergency physician at a busy hospital here in Vancouver. He's a passionate POCUS educator and clinical assistant professor at the University of British Columbia. And we're fortunate to have him as chairman of the Clarius Medical Advisory Board. Dr. Frenkel, I'll hand it over to you to educate us all on the use of POCUS in patients with dyspnea.
Thanks, Shelley. It's fun to be on the other end here for this webinar, and it's a topic that's near and dear to my heart. And I titled the talk, Diverting Death from Dyspnea. You know, in acute care, it's a really common presentation to see patients presenting with shortness of breath. And not always are they at the death's edge or critically ill, but sometimes they are. And the more sick they are, the more urgent it is for us to have rapid answers to our clinical questions so we know the next steps. And really, there is no tool better than point of care ultrasound. And I hope I can convince you of that by the end of this webinar if you're not already a believer. So the way I'm going to present and talk about the dyspnea scan, we kind of call it the triple scan. And over the years, I've rearranged the order in which I do the scan, but the fundamentals are essentially the same. And we're going to start with a lung ultrasound, which has its interesting advantages and challenges, like Shelley alluded to. And then we're going to do some quick focused echo or focused cardiac scanning. And then we will add on a bit of adjunct scanning, and you'll see why that's kind of a number 3 on the list and the last step. So you can get your answers, the quicker and more effective answers first, and then you kind of trickle in the rest of the information as you go, and you go down the scan list. So the first thing that you have to really understand, especially for some of you who are new to dyspnea scanning or using ultrasound for this clinical presentation, is that lung ultrasound is really an artifact interpretation. So what that means is when we're scanning other organs, we're looking at the organ, we're measuring it, we're seeing the ultrasound beam create an image of the organ. But when we're scanning the lungs, like Shelley said, we used to think this was sort of a no man's land, or there was nothing to see. And what we learned later, thankfully, due to a lot of work in Europe, was that these artifacts are actually predictable and they can give us really high quality information. And it turns out it's even superior to most of our other tools that we use to evaluate the lungs. And so learning to do that requires understanding what artifacts we're looking for and how we're going to interpret those. So I break up lung scanning into both a deep penetration scan and then a shallow scan. And we're going to be going through all of that and reviewing what are we looking for in each stage. So the first one is deep scanning of the lungs. And the primary question here is whether a patient in front of you has a wet lung or a dry lung. And the way we're going to do that is this is going to demonstrate a scanner. This is a phased array setting on a lung setting, but you can really use any curvilinear or phased array scanner. The key is that you have a deep setting, at least 12 centimeters down, and you're taking it with the indicator up towards the head, the midclavicular line, and we're coming down that anterior chest wall, really looking at the intercostal spaces as we go. And what we're seeing is the pleural line, and these are called A lines, and we'll get into that in a moment, but it's the reverberation artifact of that pleural line, which is going to be that superior bright white line. And then we're going to see it repeated down the screen in a healthy patient with dry lungs. That means they have a normal aerated lung. This is the artifact we expect when there's no fluid in that lung. To complete the scan, we come down the anterior, and then we're going to go into the mid-axillary line, starting kind of where we do an abdominal scan at the liver border. We see the diaphragm, and then we're going to slide up that mid-axillary line. Again, looking at the A-line pattern, there's the rib shadow, pleura with A-lines, rib shadow, pleura with A-lines, and we're going all the way back up. And that way we get a really complete look at that anterior and lateral aspect of the lung. When COVID came around, we started adding some posterior scanning as well. But as we all know, in our sickest patients, that's actually really hard to do. We can't really sit them up easily. And so we kind of take this for granted that this is what we consider generally adequate for most assessment of wet or dry lung, is this anterior and then the lateral look. And what we're looking for are these two artifacts, trying to differentiate it. And why I love lung ultrasound so much is it's so binary, generally. It's A lines or B lines. You're kind of looking for one pattern or the other pattern, and that's kind of it. So we have this A-line pattern on the left, which is going to represent a dry lung, and its contralateral example are these B lines. B lines are vertical lines that are coming down. You can see it really goes to a high depth, so at least 10, 12 centimeters to the bottom. It's obliterating that A-line pattern, and this is an artifact that's generated from a wet lung, soggy lung. If there's fluid in the lung tissue for any cause, you're going to get B lines. And if you see one B line, it can be considered normal. We often see those in the dependent regions, in the lower region segments of the lung. But if you see 3 or more B lines, or they start coalescing into a big, wide, bright spotlight like that, that's considered a positive lung zone for B lines. And it really is obvious. When you see a patient who has B-lines showing up, it jumps out at the screen at you like you're at some kind of rock music concert. It's not a subtle finding. So the second question is, you've done this whole lung scanning pattern. What is the distribution of those B-lines? Is it just in one region, like say the right lower lobe that we're seeing here, where the A lines are dominating in the rest of the scan? Or is it going to be something else? If it's localized, B lines, say just in one region, or maybe a couple little zones, but all say in one segment of the thorax, that has a pretty specific differential diagnosis. So pneumonia is really the number one cause on that differential diagnosis of patients who have focal localized B lines. You can also see it with some dense atelectasis, or in a trauma setting, pulmonary contusion can cause a similar presentation because there's some blood actually inside the lung tissue. The other distribution you're going to see is maybe diffuse B lines. The number one cause of this is cardiogenic. It's more a transitive process. There's fluid leaking out of their vasculature all over the lungs. They have frank cardiogenic pulmonary edema, and that's number one on our differential. But you need to know when you see B lines diffusely, there is a broader differential, and it's not always congestive heart failure. It can be interstitial lung disease, it can be ARDS, or even really bad multifocal pneumonias can show up with B lines that are patchy and diffuse in both sides of the chest. The reason I changed my order of scanning, I used to be all echo first for everyone, but after this paper came out, I could no longer say echo first was the way to go. And this paper came out of Europe. It's an oldie but goodie at this point, but it's really practice transformative. And in patients who presented in this study, which was a multi-center prospective study, undifferentiated dyspnea, in patients who had suspected congestive heart failure, so someone who said, I think this person probably has heart failure, they had the clinical pretest probability, and then they added ultrasound to those patients looking for B lines. That likelihood ratio of getting to a diagnosis of decompensated CHF as the cause of their dyspnea was 37.5. I have not seen a positive likelihood ratio of any other diagnostic test across the field of medicine outside of maybe CT with abdominal, an abdominal CT with contrast that can get you that kind of likelihood ratio for a specific diagnosis. And here it is in our hands, and you can get the answer in seconds. Similarly, the negative likelihood ratio at 0.03 largely rules out congestive heart failure as the cause of a patient's dyspnea if you don't see any B lines. So it's an incredibly powerful tool. And it turns out this artifact is incredible. The B line artifact is incredible at diagnosing specific CHF. And we're going to talk a little bit more about how to integrate it into your kind of broader management of patients, because not everyone is going to have congestive heart failure as the cause of their dyspnea. What's even more interesting is that using ultrasound for pneumonia is also incredibly powerful. So in this systematic review, when you have localized B lines in a patient you suspect might have pneumonia from other symptoms, again, that likelihood ratio, not quite like CHF, but it's pretty high at 17. And the negative likelihood ratio pretty good at 0.07. So really kind of helping you hone in, especially if your next step is, do I give this patient antibiotics or not? It can really help focalize and narrow your differential on what's going on with this patient who has undifferentiated dyspnea. And I like to compare it to our current gold standard tests. We have our stethoscope, which is basically a 200-year-old test. There's no way that's ever going to perform with a likelihood ratio anywhere close to what we're finding for ultrasound. And then even chest radiography, I don't know about you, but I can't really interpret chest x-rays with that kind of likelihood ratio. So I really rely on my ultrasound for these diagnoses. Other things you might find. So we did that anterior scan, and especially as we come into those mid-axillary zone scans, you'll also find sometimes as a cause of dyspnea, pleural effusions in your patients. And what these are going to look like is black. Here's our diaphragm, and here's a bunch of fluid essentially in that mid-axillary line with what we call the jellyfish sign. So the lung is collapsed and consolidated here, atelactatic, and it's flopping around in that black pleural effusion. That could easily be a cause of your patient's dyspnea, or combined with a bunch of B lines that you're seeing might be from their decompensated heart failure. In patients who have a longer term pleural effusion, there will be more kind of fibrotic and exudative things going on and floating around in there. This is a long-standing pleural effusion, either from an empyema that was sitting there for a while, or potentially tuberculosis in a more chronically ill patient, or even a malignant effusion. And then lastly, the one you need to know is called hepatization. So that's when the lung is so consolidated that it looks like an organ. So here on the screen right, we have the liver, there's the diaphragm that's well demarcated, and then the left of the screen has the lung that is basically full of pus. And it's a lobar pneumonia, and these bright white little dots are the collapsed bronchioles that are still reflecting some air. And it's so dense now that it looks like an organ because there's no air anymore. So there's no A lines or B lines anymore. It's so dense it looks like the organ, and that's hepatization because it looks like another liver, but you have to notice it's on top of the diaphragm. All right, so that's the deep scan of the lungs. From there, let's say if you find mostly A lines, you haven't found the cause of your dyspnea, or if you want to be complete, you want to switch to shallow scanning. And what we're going to do is now look at the pleura itself. And it's great if you have a scanner that can flip to a linear high frequency setting, or you just grab another one off the cart and you go to the linear scanner, which has higher frequency. And now we see basically the same protocol that we did for the deep scan, but we're doing it at a much shallower depth. And we're going to see those ribs in way greater detail. And we're going to see the pleural line that's right here, and we're looking for it sliding back and forth. This is really a different kind of artifact, and where there's a trace amount of fluid between the visceral and parietal pleura. And as the pleura slides with the breathing, that's signifying that it is normal, healthy lung, and it's moving the way we expect it to. If someone has B lines and consolidated lung, you'll see the B lines here, and you could put the depth to identify them, but really we're just looking at the pleural line itself. And the questions you're asking on the pleural line first is it sliding? Because if it's not, you think the patient might have a pneumothorax. And a pneumothorax will still likely give you A lines on a deeper scan, but when you go superficial, you'll see that there is no pleural sliding here between these rib shadows. And what we actually see on this clip is what's almost pathognomonic for a pneumothorax, which is called the lung point. So right here on the screen left, we actually see that little bit of lung sliding peeking in and out under the rib, and that's the edge of the air bubble in this patient's chest where the pneumothorax is. So here's normal lung sliding, and here's the end of normal lung sliding, where this is a pneumothorax causing this patient's dyspnea. Other questions you can ask of the pleural line are also if you see patchy B lines. So in some patients, you started deep and you saw some B lines maybe down here in the right lower lobe, maybe the left upper lobe, and that has its own differential. Could it be decompensated heart failure with a little asymmetry? Is it a multifocal pneumonia? Maybe it's interstitial lung disease. You're trying to figure it out. One thing you can look at is the pleural contour. So this scan is actually back on the deep setting, and we could either switch probes to a linear one, or sometimes you can just get your information from the deep setting, just focusing on the pleural line itself. And you're looking at the contour of that pleural line. So this time we're looking, is it rough or smooth? A rough pleural line where it looks all choppy and shreddy, sometimes called the shred sign, where that pleural line looks kind of irregular and almost discontinuous along the way, associated with these B lines, really suggests an infectious pattern of what's causing that underlying set of B lines, versus a smooth sliding set of pleural lines that's nice and crisp here, but also associated with B lines, suggests more of a transitative process like decompensated heart failure. All right, so that was the lungs. Deep, shallow, you got a lot of information, but it's incomplete. We still generally need to add some echo in any patient with shortness of breath, right? It's heart and lungs, cardiovascular, pulmonary, cardiopulmonary, it all kind of goes together. I really kind of separate this out into parasternal long axis and then the other views. The reason I do that is because I think the long axis is probably your key view, and I'm going to get to that in a second. I also want to address how kind of I demoted echo to the second scan, partly because it's a little bit harder, we'll be frank. You do lung scans, and lung ultrasound is very straightforward, and it's such an easy artifact to interpret. The echo is harder. Everybody's heart is in a different place in their chest. It's harder to generate the views. It's harder to interpret the views. And I think that's why we see in a paper like this, where the likelihood ratios just aren't as good as we would expect. We would expect doing a quick point of care echo on a patient with heart failure should be excellent. But in fact, maybe it doesn't perform as well as we thought. And part of that is that I think this is in a vacuum. And the challenging area of echo is really those moderate reduced ejection fraction cases. So the ones where we're not sure, we're not always accurate in assessing those moderate reduced ejection fraction patients. And so when you try to look at that in a vacuum, I think it comes out and shakes out not as accurate by itself. This is just looking at focused echo. But if you take lung ultrasound and combined it with echo, you already had a great positive likelihood ratio from your lung ultrasound in a patient. So the echo at that point should be the icing on the cake to help seal the diagnosis and not the other way around. Parasternal long axis is really the easiest echo of the views to generate in terms of the utility of information you're going to get. And as I'm going to show you, I have a really rapid way to interpret the scan. A lot of beginners sort of create an echo image and they sit and stare at it and watch the heart keep beating. And you really don't need to do that, especially in patients where seconds count and you need to move on and make decisions. You really need a couple beats of the heart cycle and you'll be able to answer the majority of questions that you need. And then you can add other echo views to kind of really round out your assessment of that patient, but you don't always need them to really get your at least basic picture about what to do next. So the parasternal long axis, though, you do need to know how to generate. And I don't have enough time today to go through all the nuance of how to get a good image. I'll direct you to other resources there. But the gist of it is you need a phased array probe ideally. You can still do it with a curved linear one if you need to. The indicator is up to the patient's right. You have to find a window here. And then you need to optimize the axis, both of the long axis, getting this ventricle really kind of pointing up off the screen. So you're not going to see the apex on a parasternal long axis. And you really want to be able to see the chambers line up. And what are those chambers on a parasternal long axis? So you do need to be able to orient and interpret this image. Unfortunately, we didn't learn this in medical school unless you were learning how to do ultrasound in medical school. And so we learned all these pictures of anatomy, but in the end, this is the view we need to know. It's the view that we can see the heart in through our ultrasound image. And that is going to be a couple key features you need to identify. So at the bottom of the screen is the pericardium, and then below that is the descending thoracic aorta. And then here's our left ventricle. And then here's the left atrium with the mitral valve, hop in here. This is the left ventricular outflow tract with the aortic valve here, and the right ventricle. This is an image, if you want to do any focused echo and you want to learn it, you need to commit this to memory and just have it stone cold. The good news is, once you get the long axis, you can do a cheating maneuver, I call it, and score a super bonus view, which is the short axis. So you've already found your window and you've kind of put in the work to get that long axis. And as Dr. Cook here shows, just by rotating the transducer 90 degrees, you can also get a short axis. So it's sort of like a 2-for-1 second cardiac view. And sometimes it's really helpful to have this. We're going to show a quick example later about where this really helps seal the deal for you. And on this view, there's really only two things to know, the left ventricle and the right ventricle. You do need to know about where you are in the heart because you could image the heart in a short axis at the apex or up at the valves and maybe get a little confused. But once you learn a little bit about where to maneuver that transducer, if you do it right, you just get the two chambers. And what I like to say is you've got the donut and the croissant, and it really helps people learn, okay, those are the two things I'm really looking for on the short axis. So now, these are my 3 rapid questions that you need to be able to interpret on every long axis. Every learner and every student I have who learns ultrasound kind of commits this to rote memory and asks these 3 questions every time they do a long axis scan. And it gets them in the habit of really looking at the things they need to look at so that you don't miss anything. And that is there a pericardial effusion? Is there a significant decrease in left ventricular function? And then the rule of 3s, which is the 1-1-1 rule is another way of calling it. And I want to just highlight, I use this specific language here, significant decrease in left ventricular function. The reason is, again, that middle zone of the moderate reduction in ejection fraction is a very challenging maneuver. It's a very challenging diagnosis. And I see a lot of error made when people are trying to guess if there's a reduction in the left ventricular ejection fraction or not. But if you draw the line at a significant decrease, like essentially moderate to severe reduction in LV function, you're going to make a lot less mistakes. You'll be much more accurate. And since you're doing echo second after the lung scanning, it should provide the information you need to better take care of your patients. So let's walk through how these questions work. Here's our long axis. And the first question is there a significant pericardial effusion? Again, we're looking down here at primarily at the pericardium, and here's the descending thoracic aorta. A pericardial effusion will come and dissect, it'll be black fluid generally here, and it's going to go in front of the descending thoracic aorta. If you see fluid going behind the descending thoracic aorta that is deep to it on the screen, that is a pleural effusion, not a pericardial effusion. Okay, and you should be seeing that already on your lung scan. If you did it in the mid-axillary zone, you should see a pleural effusion. If it's big enough to show up on your long axis view, you should have probably already seen it on the thoracic scan. But here's another way you can check it. And this is what a pericardial effusion would look like. So here's a heart. There are other findings on here, but I'm bringing your attention to the pericardial effusion. That's the first question. Here's the black fluid going in front of that descending thoracic aorta. In this patient, we can also see it in the anterior screen. There's a bit of black here. And like I said, there are other findings in this patient, but we're really focusing first on this pericardial effusion. And the reason I make that the first question is because when seconds count and you have a very sick patient, especially who's hemodynamically unstable or critically ill, if they're shocky or hypotensive and short of breath, if you see a pericardial effusion, that's probably the first thing you need to address, and they might be in tamponade. And so in terms of what's going to basically kill that patient first, that you need to intervene, it's the pericardial effusion. So always ask that question first.
So I guess just to interrupt you for a second there, Dr. Frenkel, if it would be important not to start with your depth too shallow, because then you're not, I guess you want to see that descending thoracic aorta.
That's right. Yeah. So this is when you're setting
can...
up your view, that is exactly right. You want to make sure that you see the descending thoracic aorta at the bottom of your view when you're setting up the long axis. I have seen the case where the depth was basically at the bottom of the heart, and people missed a large pericardial effusion because it just kept going off the screen. Absolutely, Shelley.
Makes for pretty heart pictures, but you might miss the big picture, right?
Yeah, and that's the one thing you really don't want to miss.
Right.
Okay, great. And then the next question is the LV severely diminished? So looking at the LV, the way we're going to assess that is we're going to look at the kind of squeeze of the cavity. So we want to see the black, which is the kind of the left ventricular cavity squeezing between systole and diastole, and we want to see it squeeze by about a third. This is an eyeball measure, and it's called the fractional shortening. To quantitatively measure the LV is another topic altogether, and I would direct you to other webinars where we kind of go way into more in depth on how to quantify LV function. But as a quick eyeball measure, when you're just trying to see, is this really the cause of my patient's dyspnea? I try to eyeball that third squeeze of the LV. The other thing you can quickly eyeball is looking at the anterior leaflet of the mitral valve. It's called the septal slap. We want to see that anterior leaflet getting very close, if not actually slapping the interventricular septum here. And that's also a proxy measure for a good squeeze where the LV is squeezing most of the blood out that's in there. It's certainly not severely diminished. As a contralateral example, here we go. So looking first, is there a pericardial effusion? No, no pericardial effusion. Second question, is the LV severely diminished? And yes, the LV systolic function here is severely diminished. There is not a third of squeeze of that left ventricular chamber here, and that anterior leaflet is not going anywhere near that septum. The quantitative measure is approximately a centimeter for what's called the EPSS, the endpoint septal separation. But again, to get more in depth in that question, I would divert you elsewhere. Okay, the last question is the 111. So it's basically everything else. We've looked, is there a very big pericardial effusion? Is the LV function severely diminished? Now, what about the rest of the chambers? And you can do a quick cognitive eyeball maneuver, which is called the 111 or the rule of threes. And it's basically a gift from the creator that the RV, LVOT, and left atrium in this view essentially are all approximately equal. Thankfully, that is a really great cognitive measure tool. So you can check your work. You can look at all the chambers and say, oh, they're about the same. What it looks like when they're not is problematic. So the first question, is there pericardial effusion? LV systolic function, you check. This one's actually hyperdynamic. And then you do a quick eyeball check of the three chambers and you say, oh, look at this patient. Well, that RV is way bigger than the outflow tract in the left atrium. That could be the reason my patient has dyspnea. That has its own differential diagnosis. It's not always a PE. A lot of patients have pulmonary hypertension or other causes of why they may have a large RV, but it certainly gives you a clue into why this patient is sick. Another thing you certainly don't really want to see in your patients, but it might be there and give you the clue to their diagnosis, is the LVOT. So in this patient, is there big pericardial effusion? Actually, this one's a trick because the answer is yes, and we're not seeing it dissect down to the bottom. This is actually localized hemopericardium in the front. But the LV systolic function is hyperdynamic. This heart is doing everything it can to pump. That LV is squeezing, its chamber is like essentially collapsing in the long axis. But the thing that does catch your eye is that LVOT is really big, and you can even see the dissection flap in this patient. This is a critically ill patient with a type A aortic dissection. Last one is the left atrium. So there are other findings here. There is no pericardial effusion. The LV systolic function in this patient happens to actually be significantly reduced, but I thought it was a great example to also show you the left atrium. The left atrium is basically the hemoglobin A1C of cardiology. So it didn't get there overnight. It's not some acute decompensation. It's generally a sign that this patient has been suffering with hypertensive heart disease probably for quite some time, and they have some remodeling, and that may be the cause of why they're sick. They could have heart failure with preserved ejection fraction or something along those lines, but it doesn't quite nail the diagnosis for you. Okay, so we've done lung, we've done heart, and now I call it the hypothesis checking phase. So you have by this point, you should generally have a differential diagnosis and know what's going on with your patient. And you have a couple quick scans where you can check your work. If you think what's going on, by adding another 15, 20 seconds, just to make sure you're on the right path. The main one we use here is the IVC, and the DVT is really specific around right heart pressures. The IVC scan, again, you can do it either with your phased array probe in a cardiac setting, in an abdominal setting, or you can use a curvilinear probe in an abdominal setting or a cardiac setting. It really doesn't matter. You find it in the same place in the body every time. And where it's going to show up on the screen will largely be different whether you're doing an abdominal scan and the indicator is to the left, or you're doing a cardiac scan with the indicator to the right. It can get kind of confusing, or the indicator is to the left, but the probe is flipped. Either way, it's going to look the same on the screen, and you're trying to assess where that IVC enters into the right atrium. And to keep matters really simple, there's a whole separate debate around how valuable and useful is IVC interpretation. And that's why IVC is number 3 in your triage of ultrasound scans, because by the time you get to the IVC, you should really already know what's going on with the patient. You're basically checking your work. And what it's going to try and do for you is, I really want you to separate it into a really dichotomous question. Is it fat or flat? Everything in between is murky. It's murky waters, and you're not really sure what to do with that information. I don't recommend measuring the IVC generally because, it's so easy to make errors, and it's just going to send us on these rabbit hole voyages of getting the wrong answer. And we're all about trying to be more accurate with our patients. So if you can assess whether the IVC is fat or flat and whether it matches your hypothesis, that should basically get you most of the information you need. And the reason I break it up like this is the flat IVC is really a sign that there is a low right heart pressure. So these patients generally are hypovolemic, or they're severely vasodilated, and that's what I'm expecting in a really septic shock kind of patient. And it's very specific finding. It's hard to mimic a flat IVC from any other cause, versus a fat IVC has a really broad, non-specific differential rate, right? So any cause of elevated right heart pressure is basically going to potentially give you a fat IVC. And that can be from decompensated CHF, but also our COPD patients who have bad pulmonary hypertension, or really any cause of tricuspid regurgitation is going to cause a fat IVC. And so you can have patients who actually need volume, who will be volume responsive, but have a fat IVC. And so it doesn't really help most of the time in assessing the differential. And I definitely don't recommend starting at the IVC. I recommend ending there. Your last quick scan is the DVT scan. It's often neglected, often forgotten, and so critically useful in those times where you need it most. And I'm going to show you where in a moment. The way you do it is this time you need a linear scanner. So either you take that same scanner and switch it to a linear high frequency setting, or you grab that one off your cart. And we are going to look in the femoral region. If you're doing a quick scan on a dyspneic patient, it's up to you whether you do a full leg scan. Again, there's a lot of nuance around doing the DVT scan, and we're not going into the depth of it. But you really need to see the saphenous takeoff, which is what we were seeing here. I can play that one more time. You see the saphenous takeoff of the vein from the common femoral vein. That's generally where most clots will form in the proximal femoral vein. So right there, we're looking for it to squeeze, and then we're going to take it down to the bifurcation of the femoral veins as the first scan. And then to complete the DVT scan, then we slide down to the popliteal fossa, and we do a quick scan of the popliteal vein from at least as proximal as we can see it down to the trifurcation generally into the calf veins. Again, there can be a lot more nuance here, but sometimes when you need the answer, the DVT scan can really provide it for you and check your work. This is the quick DVT scan I wanted to show you. So this is what it's going to look like when you compress the vein and that there's a thrombus. So there you're applying the pressure and that vein's not collapsing. There's the saphenous takeoff right here, and that one has a thrombus in it. All right. This is how we're going to hammer this home. We're going to do a couple cases. These are all real cases I've been involved in. It's not specifically the pictures of the patients, and I'm pulling their vital signs from memory, but and some of the scans aren't exactly, but these were all cases that I actually saw where the ultrasound totally kind of helped hone in the treatment and management and changed everything for us. So here's a great example. 65-year-old male brought in by the ambulance, has a history of CHF and COPD. This is the classic, like, how are you going to tell? They're short of breath. It's been a day of shortness of breath. The paramedics he's wheezy throughout, and they start throwing cognitive anchors at you. Oh, he has lower extremity edema. He's been laying down. He's having a hard time breathing while he's laying down. He hasn't taken maybe his meds for a couple of days. This is a pretty classic case we see not infrequently in the emergency department. And then you get in and you say, okay, well, he's not really that sick, but if the stats were lower or some of his other vital signs were looking worse, I'd have to start intervening pretty fast. Am I going to diurese? Do I do BiPAP? This patient usually has a history of hypertension. Why is their blood pressure only 120 when I expect them to be 180 or higher maybe? What's going on with this patient? So you grab the ultrasound, you take a quick look. If it's CHF, you're expecting to see B lines everywhere. And instead, you just see them in the right lower lobe. It's like, oh, that's interesting. Okay, that doesn't really look like CHF. Maybe he has a focal infection. Maybe that's your running diagnosis on your differential. And then you take a look at the heart. This is a patient with a history of CHF. This is not the heart you expect to see on a patient who has decompensated heart failure, right? This is a hyperdynamic left ventricle. There's no pericardial effusion. Again, that was the first question. And then that left ventricle just catches your eye. Wow, it's slamming. This guy is working really hard to basically do whatever he can to keep up. This is not decompensated heart failure, right? So focal B lines with a hyperdynamic LV, I know this patient probably has bad pneumonia, and they really are relatively hypotensive. I expect this patient has a history of hypertension who hasn't been taking their medications for a couple of days, shouldn't have a blood pressure of 110, 120. They should be 180 plus, which is where they usually go if they don't take their meds. So they're relatively hypovolemic probably, and maybe they actually need fluids to help them out a little bit. And to match and fulfill my hypothesis, I take a quick look at the IVC, and boom, I see a collapsing IVC with respiratory variation. This is matching my hypothesis that this patient is likely relatively hypovolemic or vasodilated. They are largely kind of going down the pathway of septic shock, not decompensated CHF. I'm not going to give this patient diuresis, even if he did have wheeze, crackles, or lower extremity edema everywhere. I know this patient probably needs a bit of fluid to help them boost back up and get good perfusion of their end organs, and probably early antibiotics for that focal pneumonia. All right, next question. This is one that terrified everyone who was involved. There's a patient who, I'm pulling the vitals out because I don't remember the exact triage presentation vitals, but this patient was not put in a high visibility bed. They were sort of, oh, she's had some shortness of breath for a couple of days, doesn't take any medication, she's healthy, was in her early 20s, and was put into an acute care bed, thankfully, I think because she had a low oxygen saturation, but no one seemed to be taking the case very seriously. And then we went and talked to her, and it's been at least 2 days of shortness of breath, getting worse to the point where now even speaking full sentences is getting a little hard, but she was able to converse and have a normal conversation with us. And so we start doing the scan. And the first thing we see is A lines everywhere, right? Dry lung. There's no sign of fluid in these lungs. These are normal sliding pleura, and there's nothing really that we can find on the lungs. Okay, so we flip to the echo as our step 2. And just as we're starting to do the echo, she starts to get a lot sicker. So she starts to kind of gasp a little more. We're repeating the vitals, and her blood pressure starts dripping, and pretty soon she's hypotensive and her sats are going down. And what we quickly see here is there's no pericardial effusion, that LV is beating pretty strong, and that RV is significantly enlarged. And everyone says, oh my God, does she have a huge pulmonary embolus? Now we know there's a lot of controversy and pushback on doing anything different on your submassive pulmonary embolus patients, and that's a separate topic altogether. But once a patient enters into a massive pulmonary embolism territory and they become hypotensive, they're shocky from a pulmonary embolus, the treatment of choice is thrombolytics. And in this patient, this is a separate short axis view. This is why we kind of had the bonus view. People love this on a PE because when you see that flattening, it's not a happy donut anymore. This is a sad squish donut. Nobody wants a squish donut, and you have that D-shaped septum where it's flattening from the large RV pressure. This patient, everyone's, oh my God, she's having a massive pulmonary embolism and she's getting sick right in front of our eyes. And then there's paralysis on the care team. Do we push the lytics? Her pressure's dropping. She's looking awful. She's becoming kind of, pre-morbid peri-arrest, and everyone freezes. She's too sick to send to the CT scanner. And then I actually wasn't the main provider in this case. I was just helping out with the ultrasounds. And then I said, guys, let's look at the legs. No one wants to push lytics unless they're sure it's a PE. Everyone's heard the kind of horror stories of, maybe there's pulmonary hypertension undiagnosed or something else. No one wants to do it unless they're 100% sure and they want the CT scan. But sometimes your patient's too sick to get the CT scan. And that's where the DVT is really your savior. We took a quick look at her legs. Boom, there's thrombus, obvious thrombus. So now we know the diagnosis. RV pressure is high. This patient has a massive pulmonary embolism now. She needs the thrombolytics. And of course, she went on to get way better, thankfully. Okay, the last question is another one that really threw us for a loop. 18-year-old comes in with kind of upper respiratory tract infection-like symptoms. Mom came in with him, said, oh, he's had a runny nose and a cough. and he's been coughing more. And then he started complaining about shortness of breath this morning, and now he's like barely arousable. So they kind of wheel him in. This guy goes straight to the resuscitation bay because all of his vital signs are abnormal, and he looks really bad, sweaty, shocky, pale. And so immediately the nurses, 2 IVs in him, the fluids are running, he's septic shock. Everyone kind of jumps into septic shock mode, right? Blood cultures, we're doing the fluid resuscitation first, get him at least a couple of liters resuscitated. But being the prudent physicians we are now with ultrasound, we jump in and take a look. First, we go to the lungs. Wow, there's beelines everywhere. Oh my gosh, this must be a really bad pneumonia. We're thinking, respiratory tract infection, sick. It kind of matches. Everyone's anchored on this respiratory infection that he has. And it must be multifocal pneumonia. Maybe it's even Staph aureus pneumonia, which we see sometimes in young patients who are really sick. But then we go to the echo. And when we go to the echo, I stop and I say, wait a second, stop the fluids right away, right? There's no pericardial effusion. That LV is not the LV I'm expecting in an 18-year-old who's in septic shock from multifocal pneumonia. This is the LV of maybe someone who has either bad coronary disease, is really old, or has a dilated cardiomyopathy or some other issue. There's no pericardial effusion, but this LV is not squeezing. That fractional shortening is awful. We already saw this clip earlier, that anterior leaflet of the mitral valve not getting close to the septum. So this is a severely diminished left ventricle. And you can't immediately explain it in this patient. There's 2 possibilities. One is they either have severe myocarditis along with their viral infection potentially, and they're actually in decompensated heart failure and in cardiogenic shock. Or sometimes patients in severe sepsis can get myocardial stunning as well and have a concomitant cardiogenic failure. Either way, fluids are not going to help this patient, and it's going to probably make them worse, and they're going to end up intubated way faster. If you hang 2 liters of fluid, that oxygen saturation is going to drop precipitously, and you're committing them to a ventilator. To test my hypothesis, we're going to jump to the IVC, and there it is, fat. This is not the IVC, again, of a septic shock vasodilated patient. This is the IVC of a patient in cardiogenic shock. So putting that picture together, we quickly stop the fluids. This patient needs vasopressors, not fluids, to get their pressure up, early antibiotics, septic care for whatever's causing this heart problem. So I hope those cases really help bring it home, that it really can change your management. And I like it, really, it checks our cognitive anchors, it checks a lot of our assumptions we have, and it helps us do better for our patients. And this is really the order after 10 plus years of doing ultrasound that we've settled on, of really go to the lungs first. It's the easiest part to scan. It's the easiest to generate the image, easiest to interpret the image. And in terms of bang for your buck, that's where you're going to get the majority of your answers. Then focus on adding an echo. Really start with the long axis. It's going to get you that quick information, especially if you learn to ask those 3 rapid fire questions. And then you can check your hypothesis at the end and maybe save a life on your next shift. And to bring home how point of care ultrasound has really elevated my practice over the years, I think we've seen over and over again improved patient outcomes. All these patients would have had worse outcomes if we had committed to our original cognitive plan and how we were going to manage them. And instead, we kind of switched gears and realized what we were doing wrong. And in the end, especially in places that don't have access to additional resources, we can reduce costs and avoid getting unnecessary tests. And as a clinician, you feel more empowered, being able to make more accurate assessments of your patient and knowing exactly what's going on. Instead of relying on the stethoscope, you have that ultrasound in your hand, and you can get such higher quality information with those likelihood ratios. And ultimately, especially in our sicker patients, they really appreciate you going the extra mile and getting those diagnostic tests on them and really making a difference in their outcome. So with that, I think I am done here.
Awesome. Thank you. That was fantastic. Lots of great information in there. I continue to learn about these things that I'm not used to scanning as a sonographer. I do have a model here, and I'm going to just switch over my camera to the bed here. So as I mentioned, I have the new PAL phased array linear scanner. So I don't know if you can notice this, but here's the phased array part of it, and then the linear is along the other side. You can quickly change which array you're scanning with by either changing the preset that you're imaging with, or I'll show you a little trick in a few minutes, but you can actually use one of the buttons on the scanner to change which array you want, and it will change to the appropriate preset. So I'm going to start with deep lung scanning here, as we talked about. And so you can see that I'm on the deep lung preset here, and we're seeing rib shadows up here, rib shadow, and here are our A lines.
Yeah, great.
Here. You can have a good look around, and then just bring your arm up, and then if we go down to the side, we can assess.
So we saw the liver there for a second. Yeah.
Yeah,
And then
I'll
slide
go
up.
back
Good.
down to that because I'm going to just demonstrate like a little trick here. So if we continue down, and if I want to see a little bit better image of the diaphragm, I'm going to do a little cheat here, and I'm going to use the abdomen preset because it gives me a nice depth, and it also lets me see the liver and diaphragm really well. Great. So then if we go back up to the lung preset again, scan all the way up to the axilla. And then what I'm going to do, if I want shallow lung setting, I'm going to just press my button. That is going to switch the array. Inner lung shallow, and now I'm in the linear array, a more shallow preset. We've got rib shadow here, and nice lung sliding.
Nice.
So it's really quick, really easy.
Awesome. And one trick, you could start even on shallow. And then if you're seeing the A lines and you increase the depth, there's no B lines there. So the reason we go to depth for the B lines is to make sure that it's not a little rocket artifact from the pleura, and that it's actually a B line, that it's in the lung tissue and not in the pleura.
Okay. All right, so then I'm just going to change to the cardiac preset here. And you'll see that we were in the linear array, and now the system is going to, I'm going to have you roll on your side. I like to always scan my echo patients on their left sides. I just get better imaging here. So
yeah.
Great.
Nice.
So we're in the phased array. And our first question, cardium here. This is the descending thoracic aorta. And so we don't see any fluid there, nor do we see any anteriorly.
There you go.
Great.
Beautiful. Yeah. And
Great.
LV function, 1, 1, 1.
Yeah.
Great.
Great. And there's our 1, 1, and 1. And then I can always, just turn 90 degrees and look at the short axis. And there's our donut and croissant.
Yeah. Yeah. The cheater view. Yeah.
Yeah.
I love it. Perfect. Yeah. And you showed good. It's as people get kind of deeper into this, right, you can do short axis at the valve level, at the mitral valve level, down at the apex.
Okay, and then we'll just get you on your back again. And then the last view that we'll do here is just to do a quick assessment of the inferior vena cava. So I'm going to just switch to the abdomen preset just because it optimizes all of the settings for me. I don't have to mess around. And there's our nice inferior vena cava right here, emptying into the right atrium. So lots of variation with respiration. And sometimes you could get, if your patient is cohesive enough, you can get them to do a quick sniff. Yeah, and then they'll collapse it as well. Sniff again. Great. Good.
Nice healthy patient.
Yes. I know how to pick them.
Yeah, nice. Yeah, no diverting death on that one.
Thank you so much, Shelley, for the fabulous live scanning. It's always exciting to see the new Claris PAL HD3 in action. Before we open up the floor to live questions with Dr. Frenkel, I invite you all to take this next poll to let us know if we can provide further information about Claris wireless ultrasound, whether it be the new PAL or any of our phased, convex, or linear scanners. Do click on as many options as apply. Pricing and availability does vary by region, so feel free to request a quote and pricing. You may opt to speak to one of our experts about the advantages of wireless ultrasound. If you'd like to discuss scanner features, please select that option. You can also book a virtual one-on-one demo with our clinicians to see Claris HD3 in action in a highly interactive session. And we can send you short video tutorials from our Claris classroom featuring Dr. Frenkel and Shelley and other emergency physicians. Please go ahead and select as many options as you wish. While you complete the live poll, I'm excited to introduce you to the new Claris PAL HD3 dual array wireless scanner for whole body ultrasound. It's FDA approved and currently available in the USA. With an innovative dual array design that fuses a phased and linear array on a single head, it delivers unsurpassed versatility, superior image quality, and streamlined workflows. It stands out by offering the broadest frequency range at 1 to 15 megahertz and greatest imaging depth to 40 centimeters, making it the ideal handheld for clinicians seeking the ultimate in image quality and diagnostic flexibility. Claris PAL supports a wide spectrum of clinical applications with whole body imaging of superficial to deep structures. For instance, you can click a button, as you saw today in Shelley's demo, to switch between presets for a seamless transition between deep and shallow lung, cardiac, and vascular imaging. Clinicians say they can perform 95 to 99% of bedside exams with a single scanner, eliminating the need to swap probes, reducing interruptions, and improving workflow continuity. Claris scanners are powered by AI, 192 piezoelectric elements, and not one, but 8 beamformers, delivering up to 8 times the processing power and frame rates of other handhelds. You get the performance and image quality of compacts in a small, ultra-portable device for a mere fraction of the cost, representing 80 to 85% savings. And with AI replacing complex knobs and buttons, it's as easy to use as your smartphone. High-definition imaging supports precise diagnoses, so you can formulate treatment plans with confidence quickly. Superior needle imaging improves the accuracy and safety of biopsies, nerve blocks, and vascular access procedures with no wires to get in the way or infect your sterile field. Simply use a sterile bag or give your Clarius a wipe after procedures. Claris is also IP67 rated, waterproof, and fully submersible for rapid disinfection. Lightweight and ultra-portable Claris scanners require zero footprint and feature the latest antenna technology for the most reliable direct Wi-Fi connections to your iOS or Android phones or tablets. With no wires or bulky carts limiting monitor placement, you can easily share real-time imaging and talk patients through their exams, fostering engagement and boosting their confidence. Only Clarius delivers wireless scanners with a complete ecosystem that includes an easy-to-use app for your iOS and Android devices for unlimited users. Available with our membership, exam management is easy. Seamlessly save images and videos to your PACS system through the current DICOM web standard, or use Claris Cloud to securely capture and manage unlimited exams from anywhere. Your membership also includes in-app Claris classroom video tutorials with experts like Dr. Frenkel and onboarding with a clinician. And Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. Available with membership, the Advanced Primary and Critical Care package offers additional AI-powered tools, specialized presets, and automated workflows for common generalized scanning for fast, eFast, and whole-body imaging. It includes the popular Auto Preset AI feature that streamlines workflows by automatically recognizing the anatomy being scanned and switching to the most optimized preset. We'll give you one final moment to complete the poll while watching our fun Claris PAL launch video.
Chosen one, I can get it done. Zip, bang, boom, pow, every mission one. Got that laser vision, cause I'm born a legend. Get up, get up, get up, let's roll. Ooh, I'm a drive-through thriller. Ooh, no one else does it better. Watch me, watch me, watch me, let's go. I'm stronger than you've ever seen. I got superpower. Let's go. I got superpower.
Now, just one last poll before we start our live Q&A with Dr. Frenkel. We'd like to invite you back on February 29th for our next webinar. It's entitled POCUS Skills for Your Next ED Shift, 5 Ways to Elevate Patient Care. Dr. Frenkel will be joined by emergency physician Dr. Brian Johnson as they teach essential diagnostic and procedural POCUS skills that can change your practice and elevate patient care. We invite you to pre-register for what promises to be a dynamic and educational session with Drs. Frenkel and Johnson. Please do complete this poll to save your seat, and we'll send you a confirmation email in the coming days. I'd like to now welcome back Dr. Frenkel to answer your questions. Please use the questions icon in the menu bar to ask questions, and I'll invite Shelley back as well to moderate.
Thanks again, Janess. All right, we have quite a few questions. We may go a few minutes over, if that's okay with everybody. The first question I'll jump right to is there a specific pattern with asthma?
Yeah, A-lines. So asthma exacerbations and COPD often is just a dry lung. So it's bronchospasm, which is deep and far away from the periphery of the lung. And it's just constriction of the airways, not fluid in the interstitial spaces. So you'll see an A-line pattern. It's the one time you still need a stethoscope. We call it the wheeze detector, because it's the one thing the ultrasound machines can't quite do yet, is detect wheeze. Although maybe that's an idea for future development, but yeah.
Patent that idea. All right. How many lung zones on each side do we need to scan minimum?
This is an evolving question. The best study, like the one I showed about the heart failure study, they did 3 kind of full zones. So they went anterior, they went kind of anterior axillary, and then mid axillary. Like I mentioned earlier with COVID, we started scanning posterior a bit because we found sometimes in patients we would just find B-lines with COVID specifically in the inferior posterior lung regions and nowhere else in the kind of healthier patients. There's not a really clear answer. I think, if you do, maybe one way to answer it is 3 regions on each side was sort of kind of how we were operating pre-COVID generally. But what I like is really doing kind of a full slide. There's not really much advantage in putting the probe on, taking it off, putting it back on, taking it off. You may as just slide down and then you get multiple regions as you look. And so if you do anterior and mid axillary, you kind of cover most of the lung, especially for the patients who are actually really sick. If you want to look further, especially in kids too, and you're trying to find a pneumonia, I recommend kind of going posterior as well and getting a couple regions below the scapula on the back.
All right, this is an interesting question and something I'm pretty sure you're familiar with, but it's from a paramedic working towards implementation of ultrasound in a pre-hospital setting. How would a physician like yourself feel about receiving the scans at patient arrival or by base contact for patient care timing or decision of treatment plan?
I would love it. I mean, if we have that set up, yeah, if like send me the EKG, send me the pictures, right? If you have a handheld and you can even like beam me, if the hospital would get behind kind of beaming through cell phones and things, and you could just ping me, like these are the scans coming in, I would love it if I know way better what's going on, right? Especially a sick patient, crashing sympathetic, hypertension with pulmonary edema, like you show me the B-lines everywhere and their blood pressure of 240, like I know we're ready with the nitro drip and everything set up as soon as they get there. Yeah, I don't know why we don't do that, to be honest. Yeah, there's a lot of barriers, but I would love it. And I think the first step is getting paramedics learning and more comfortable with the ultrasound skills, and then moving towards just adding the technological solutions. I don't think they're that onerous.
I think we'll squeeze one last question in here. The ability of this device to also see descending aorta dissection or AAA.
Okay, yeah. So yeah, dissection is tricky. If you're lucky or your patient's unlucky, you see the dissection flap on particularly a type A dissection, which are the ones we're really scared of, right? Those are the ones that need emergent surgery. AAA, absolutely. Like I think any phased array scanner, you could use, and you could find an abdominal aortic aneurysm, especially one that's symptomatic and causing whatever the patient's presenting with, whether it's severe flank pain or syncope or something. Type B dissections are harder. So especially once you pass the arch, it's behind the heart and the descending thoracic aorta. That's really hard. It's kind of a no man's land. If you're lucky, you'll see it on the long axis through the heart, but you're imaging through the heart, it's at the bottom of the screen. And then sometimes you'll see the type B dissections further down the abdomen, but that's harder to see.
All right, well, we are just at the top of the hour here, so I think we will stop there, and I'll just hand it back to Janess for some closing comments.
Yeah, thank you for all of your questions. We've had many, and if we didn't get to your question, or if you ask for more information in the poll, we'll follow up with you in the coming week. You will all receive a PDF copy of the slides and a link to the webinar recording as well. So do keep an eye on your inbox. I'd like to thank Dr. Frenkel for sharing his best practices with us today, and thanks Shelley for the exciting Claris PAL demonstration. And of course, a very big thank you to all of you for joining us. I encourage all of you to complete our closing survey to provide feedback so that we can continue to bring you educational webinars like today's event. We hope to see you again on February 29th with Drs. Frenkel and Johnson as they teach us 5 essential POCUS skills to elevate patient care. Until our next event, keep scanning, and we wish you all a warm and delightful holiday season. Thanks again.
Thanks, everyone. Bye.
Bye, everybody.